welcome back to the deep dive. You know, sometimes the most cutting-edge medical advancements aren't about um, giant robotic arms or AI.
Right.
They're about these astonishingly precise, human-executed procedures that rely on just perfect timing.
Split-second timing.
Today, we're pulling back the curtain on exactly one of those. High stakes, highly specialized. We're going into GI endoscopy. Our mission is to get you instantly up to speed on a critical technique used when seconds really count.
And our source material for this, well, it's not a textbook. We're drawing this directly from professional training notes. I mean, these are learning objectives from clinical education videos, specifically the work shared by Dr. G.S. Raju on YouTube.
So this is the real deal.
This is the focused, practical knowledge you need for success in the cath lab.
And we are diving into the world of glue injection, specifically the use of cyanoacrylate, and its critical role in managing gastric variceal bleeding. For those who might not know, these are massively enlarged veins, often in the stomach, that can just rupture.
And when they do, it's a catastrophic hemorrhage. It's an immediate crisis.
Right.
And that's the high-level view. The reality on the ground is that dealing with these fundic varices is, it's not just technically demanding, it's profoundly labor-intensive.
Okay.
What the clinicians stress is that preparation is absolutely non-negotiable. It's the single biggest factor for success and, critically, for patient safety.
So we need to explore the exact choreography, the prep, the execution, and the risk management when you are literally injecting medical-grade superglue into a massive, actively bleeding vein.
Exactly.
Okay, let's unpack this high-stakes prep. I mean, we're talking about using an adhesive inside the human body. What precisely is this glue, and what does meticulous preparation actually look like on the side table? I'm picturing something like a bomb squad setup.
That analogy is actually pretty apt because this glue hardens instantly. The moment it touches ions or water, it's solid.
Instantly.
The specific agent is N-butyl-2 cyanoacrylate, which is, it's a derivative of the common crazy glue family.
So it's like superglue.
Basically, yeah, but formulated for biocompatibility and very specific polymerization rates.
Okay, so you have this material that is designed to just instantly solidify. Given that speed, why can't you just measure out the glue when the endoscopist says go?
Because if a patient has an active bleed, the endoscopist cannot wait 30 seconds for an assistant to draw something up.
Right. Time is blood loss.
Every second counts. So the preparation involves pre-filling a staggering number of syringes. We're talking about preparing up to 8 to 10 syringes just for the glue.
10 syringes of glue. That sounds like a lot, unless the amount in each one is tiny.
It is tiny, and that's deliberate. Each 3cc syringe is pre-filled with only 0.5 milliliters of glue.
Half a milliliter.
Just half a mil. It's a critical quantity. You inject multiple small aliquots, which lets you control the obliteration of the varix without, dumping a huge amount of glue into the patient's circulation.
And if you're injecting something that hardens on contact with water, you must need an immediate flush agent, right?
You do. And this is where the precision ratio comes in. For every single syringe of glue, you need a matching syringe of diluent. In this case, it's distilled water.
Okay.
So alongside those 8 to 10 glue syringes, you need another 8 to 10 syringes pre-filled with 3 milliliters of distilled water each.
Wait, why distilled water? Wouldn't
Wow.
saline or, some other common irrigation fluid work?
That's a great question. The whole key to cyanoacrylate polymerization is ionic contact. Distilled water is used precisely because it's pure. Saline has electrolytes, ions, and that would make the glue polymerize way too quickly.
It would harden in the tube.
Exactly, inside the catheter, which would be a total failure. The distilled water is just the flushing agent. It's a plunger to push the glue out into the varix, where the blood itself provides the trigger to harden instantly.
That distinction, the ionic concentration, that's fascinating. It really shows how much chemistry is involved in what looks like a purely mechanical procedure. Now, equipment protection. These endoscopes cost tens of thousands of dollars. If this glue touches the scope, isn't it just ruined?
It's a massive risk, a huge risk. So the sources make it clear that a crucial and mandatory preliminary step is coating. They have to use a specialized oil, a medical-grade oil, to coat the outside of the scope and, very meticulously, the inside of the endoscope channel.
So the oil is like a non-stick shield?
Exactly. It's a barrier. It prevents any accidental splashback from curing directly on the lenses or, worst of all, inside that narrow working channel. If glue hardens in there, the scope it's done. You're looking at incredibly expensive repairs or even a full replacement.
It's a cheap bit of insurance against a catastrophic failure.
It really is.
Okay, so just to lock this in for you, we have N-butyl 2-cyanoacrylate in 0.5 milliliter shots matched with 3 milliliter shots of distilled water, all pre-filled. The scope is oiled up, and you have a stack of backup injection catheters because they're basically disposable here.
That's the logistical foundation. And once all that is verified, the very next step is securing the human element. The safety protocol kicks in immediately.
And this is where the hazard level becomes really personal. We have to talk about protecting the team and the patient because this is a serious chemical agent.
Absolutely. The clinicians insist that before anyone even thinks about injecting, the team leader has to do a full check, a timeout.
Not just a casual glance.
No, it's a hard stop. Every single person in that room, endoscopist, nurse, technician, must be verified as fully protected by their PPE.
What's the one non-negotiable item on that checklist?
Eye protection. Mandatory goggles or shields.
Makes sense.
Imagine if a tiny drop of this stuff splatters onto your cornea. It hardens instantly. The potential for severe, irreversible eye damage is, well, that's why this check is elevated above everything else.
And the patient is right. They might be coughing or moving. Their eyes are also exposed.
Precisely. Patient protection is mandatory too. The patient's face, especially their eyes, has to be covered or shielded to protect them from any unforeseen splatter.
It's a comprehensive barrier against a material that just does not forgive.
It doesn't.
Okay, so once everyone is prepped and protected, the intense, almost theatrical choreography begins. This is where the coordination has to be just flawless. What is that rapid-fire sequence of events?
The first step is all about speed and setup. The injection catheter gets primed with distilled water, no air gaps. Then the endoscopist punctures the varix. That's the moment of commitment.
And what happens in the millisecond right after that puncture?
The assistant starts the rapid injection cycle. They quickly push that pre-measured 0.5 milliliters of glue, but, because of the catheter's length, that little bit only travels partway down the tube.
It's still in the line.
It's still in the line. So it must be immediately followed by the assistant flushing with 1.5 to 3 milliliters of distilled water. The water is the high-speed plunger that forces the glue out the tip and into the varix.
Wow. And the endoscopist is completely focused on the screen, not the assistant's hands. If that flush is too slow, the glue hardens inside the catheter.
Exactly. The margin for error is fractional. A 1-second hesitation and the catheter is useless. This is why communication is the only true link they have.
So the assistant has to call everything out.
Loudly and clearly, like an air traffic controller. It's highly specified. They'll announce, glue is going in, 0.5 milliliter injected, immediately followed by distill water going in, 1 milliliter, 3 milliliter injected.
And then what?
And then, critically, next glue is ready. This constant audible confirmation keeps everyone in rhythm.
Meanwhile, what's the endoscopist doing with the needle that's still physically inside this vein?
This is a subtle but brilliant technique. While all this rapid injection is happening, the endoscopist has to continually jiggle the needle.
Jiggle it.
Yeah, jiggle the catheter in and out of the varix wall, just a slight controlled motion.
The jiggle. Why is that tiny motion so vitally important right then?
It's purely preventative. Remember, the glue is hardening instantly inside the varix. If that needle stays still, the glue will cure around the needle tip.
Cementing it in place.
Exactly, cementing the catheter into the varix wall. And now you have a massive complication. The jiggle ensures the needle stays mobile just long enough to be withdrawn safely into its sheath.
That completely changes how I picture this. It's not a static injection. It's this dynamic, coordinated dance with instant setting chemicals.
It really is.
So let's talk strategy. When they approach these bulging varices, where do they aim? Do they just hit the center of the bulge?
No, absolutely not. The targeting is strategic. It's all about safety. Expert endoscopists will start the injection at the periphery of the varix.
The edge.
The base or the edge of the bulge. They only move toward the center later on, if they even need to.
And what's the rationale there?
It's anatomy. The central part of the varix, the biggest part of the bulge, is actually the thinnest part of the wall. It's the most likely to rupture.
So starting at the periphery is safer.
Much safer. The tissue there is thicker, more structurally sound. And clinical evidence shows this approach dramatically cuts down the risk of causing a bleed during the injection itself.
So after this intense series of injections, how do they confirm that the job is done? I mean, they can't just look at it.
They need tactile confirmation. Once the glue is in, the endoscopist pulls the sharp needle back into the catheter sheath. Then they use the now blunt end of the catheter tip to gently palpate the varix.
They're literally pressing on it.
They're pressing on it. They're feeling to confirm that the varix has lost its spongy feel and is now hard, solid, fully obliterated by the cured glue.
Confirmation by touch. Okay. Before this whole high-speed event can even be considered, you mentioned a critical anatomical check, something they look for on a pre-procedure CT scan. What is the single biggest danger they're looking for inside the body?
They are looking for the presence of a spontaneous splenorenal shunt.
A shunt.
It's an abnormal vessel that creates a shortcut, basically, bypassing the normal portal system of the liver.
And why does that shunt make this procedure a total deal breaker?
Because of blood flow. Normally, blood goes through the liver. If this shunt exists, blood from that gastric varix drains directly into the splenic vein, then the renal vein, and straight to the heart and lungs.
Oh, I see where this is going.
If you inject glue and that high-speed bypass exists, the glue can travel instantly through it.
And cause a massive embolism in the heart or lungs.
A massive, potentially fatal embolization. Exactly.
So the presence of a large shunt doesn't just make it risky, it makes it a no-go.
Absolutely. The clinical guidance is crystal clear. If a significant spontaneous splenorenal shunt is found on the CT, the procedure must be deferred. You stop, you find another therapy.
This has been a truly impressive deep dive. So, to distill what we've learned for you, glue injection is an incredibly effective tool for gastric variceal bleeding, but its success depends entirely on three pillars: that extensive chemically precise preparation, the mandatory physical protection for everyone involved,
For everyone.
and that high-speed surgical precision, including techniques like the jiggle.
And we understand now that the risks are minimized through these highly controlled processes. Injecting only 0.5 milliliters of glue at a time, strategically targeting the safer periphery of the varix, and, most critically, that pre-procedural check for a dangerous splenorenal shunt.
This level of risk management raises a fascinating, immediate question for you to consider. Given that the presence of that shunt requires deferring the glue injection entirely, what are the primary alternative therapies a clinician would pivot to in that exact scenario?
Right. What's plan B?
And what are the inevitable clinical trade-offs in efficacy, recovery time, recurring risk that come with those alternative methods compared to the certainty of the glue?
It just shows that successful clinical care is always about having multiple complex contingency plans ready to go.
Something to keep thinking about long after this deep dive concludes. Thanks for joining us. We'll catch you next time.